we're Group 7. My name is Lauren Shea.
I'm Louisa Smith.
I'm Magnotto.
And I'm McCarthy.
Do stress-relieving techniques improve stress levels and general health of diabetes patients?
So our population was patients with type 2 diabetes. Our intervention was various relaxation methods. Our control was no intervention. Our outcome was stress levels and general health. And our time frame was while the patients were receiving care or treatment.
This was a problem-focused trigger, so low socioeconomic status led to greater risk for diabetes due to their constant higher stress levels.
So chronic stress is where the body pumps out an excessive and unhealthy amount of cortisol and adrenaline, inhibiting the body's ability to synthesize glucose and adrenaline, resulting in a greatly increased risk for diabetes.
We analyzed 4 articles. The primary difference between the articles were the methods of stress relief that were engaged, and the patient groups all focused on adults with diabetes.
So our first article was measuring possible effect on health-related quality of life by tactile massage or relaxation in patients with type 2 diabetes. The aim of this study was to study the effect of tactile massage versus relaxation exercises via a CD on health-related quality of life, HRQOL, in patients with type 2 diabetes. Tactile massage is a form of massage that does not manipulate the underlying muscles of the patient. It is a very soft massage that massages the patient's whole body while relaxing music is being played in the background. The relaxation CD also lasts for an hour and consists of 5 exercises along with piano background music. The study is a quasi-experiment level 3 evidence in which the patients received the intervention over a period of 10 weeks. The study consisted of 21 type 2 diabetes patients taken from primary healthcare centers in Stockholm County, Sweden. The participants fell between the ages of 35 and 75, all of Swedish origin, men and women. The participants were semi-randomized by being drawn alternatively to the TM and relaxation groups manually by an independent subject at the research center. 26 people ended up in the TM group and 27 in the relaxation group. The study uses a questionnaire called SF36 that quantifies health-related quality of life. Body measurements and blood samples were also collected. Data was collected before the intervention at baseline, after the intervention period of 10 weeks, and 3 months after the study had ended. Both the TM and relaxation with CD groups had an improved health-related quality of life, however, not at a significant level. There were also no significant differences between the two methods. One of the main limitations was assessing HRQOL. It was very difficult due to a ceiling effect from the baseline being already high among the participants. This limited the likelihood of finding an increase after the intervention. Also, if the intervention was given more frequently than once a week, there could have been a greater effect. The sample size was also very small. The strengths included both men and women in the sample. It also analyzed with intention to treat and used a well-validated HRQOL instrument, the SF36. In conclusion, no metabolic increase or significant change in health-related quality of life was proven in this study due to the ceiling effect and a very small study size.
Alright, so first, before I begin our next article, here are just some brief terms that help when you're going through so that you know what the abbreviations stand for. So my study was the effects of music therapy and music-assisted relaxation and imagery on health-related outcomes in diabetes education. And the purpose of this feasibility study was to compare the effects of music-assisted relaxation administered via CD recording without therapeutic intervention to the effects of music therapy facilitated by an onboard music therapist on selected health outcomes of patients enrolled in diabetes self-management education and training. The sample population consisted of a 3-group parallel randomized control trial with 199 patients aged 30 to 85 years old with either type 1, type 2, or prediabetes. 32% of the 199 patients were male, and 189 of the patients had type 2 diabetes. Eligibility included physician referral and admitting diagnosis of diabetes or prediabetes, and patients with gestational diabetes or other types were excluded as well as those with medical statuses preventing them from full study participation. Other exclusions included dementia and severe hearing loss and prior participation in the music therapy program at the study sites. The research design was a pre-test, post-test experimental design, and data was collected 2 weeks prior to the intervention as baseline, and follow-up data was collected 3 months after the study enrollment. Measurement tools were the patients that were involved in a study from 2 hospital sites and randomly assigned to a diabetes self-management education training alone, the music-assisted relaxation and imagery, or both the diabetes self-management education and the music-assisted relaxation. Outcome measures included taking patients' blood pressure, glycosylated hemoglobin, body mass index, trait anxiety, state anxiety, and stress. There were no statistically significant differences among the 3 conditions in blood pressure, glycosylated hemoglobin, BMI, trait anxiety, or stress. The study results support the relationship between diabetes self-management education training and the improvement on all measured outcomes except blood pressure. Results suggest that integrating music therapy and diabetes self-management education with music-assisted relaxation to lower systolic blood pressure of patients with diabetes and comorbidity of hypertension. Significant changes over time were evident in the music therapy condition from the pre to post test each session in systolic blood pressure, state anxiety, and stress. The limitations for this study included a small sample size related to smaller diabetes and self-managed education training census than projected results in failure to achieve the necessary statistical power to test the null hypothesis. Additionally, some distracting sounds were audible from the hospital's paging system, which could be considered distracting for patients trying to focus on their relaxation therapy or listen to music. The implications of this study was that relaxation therapy research with patients with diabetes has really virtually been ignored by researchers over the past decade, and there's been limited study of anxiety and psychological stress in relation to self-management diabetes, even though we know the importance of stress and its effects on the disease. The strengths of the study include that there were no significant differences between groups at baseline with respect to age, gender, diagnosis, hypertension, medicine usage, or blood pressure. Baseline and follow-up data collected by a member of the professional staff at the 2 hospital sites ensures collection of quality data. Giving the definition of music therapy as a clinical and evidence-based use of music intervention to accomplish individualized goals within the therapeutic relationship by a credentialed professional who has completed an approved music therapy program ensures an understanding of the meaning of music therapy for anyone looking to replicate the study. And additionally, the study required a credentialed professional to work with the study subjects to assure a proficient and skilled therapist. The therapist had also interviewed the patients and chosen music that the patient would enjoy based on personal preferences. And lastly, the music therapy patients were required to attend at least 3 of the 4 scheduled music therapy sessions for their data to count in the study. And this was in order to yield enough information to influence the results.
The study I critiqued was mindfulness-based stress reduction is associated with improved glycemic control in type 2 diabetes mellitus, a pilot study. The purpose of this study was to estimate changes in glycemic control, weight, blood pressure, and stress-related psychological symptoms in patients with type 2 diabetes participating in a standard mindfulness-based stress reduction program, hereafter referred to as MBSR. This study sought to engage persons aged 30 to 75 with type 2 diabetes with glycosylated hemoglobin values between 6.5 and 8.5%, as well as a fasting blood glucose level above 275 milligrams per deciliter in an MBSR program. 14 participants enrolled, 5 men and 9 women. The mean age was 59.2 plus or minus 2.57 years. The average time since the diagnosis was 7.36 years. 10 of participants were Caucasian and 4 were African American. Those who were not eligible to participate in the study were those who had changes in diet, medication, or exercise within 12 weeks of beginning the study's intervention, those with a significant psychiatric diagnosis, as well as those who were currently involved in a meditation-based practice. The study was prospective, observational, and at the 3rd level of evidence. The measurement tools utilized in this study were measurements of glycosylated hemoglobin, measurement of fasting blood glucose, measurement of weight, heart rate, and blood pressure, and use of Symptom Checklist 90, the revised edition, which indexes participant responses for anxiety, depression, somatization, and general psychological distress scores. The results of this study found that after participation in a standard MBSR intervention for 8 once-weekly, 150-minute sessions, a singular 7-hour weekend session, as well as the home session showed that there was a 43% reduction in symptoms of depression, 37% reduction in symptoms of anxiety, and 35% reduction in general psychological distress. The p-values for these findings were 0.03, 0.03, and 0.07 respectively. At 1 month after follow-up, the following results were noted. A statistically significant reduction in glycosylated hemoglobin values of 0.48%, p-value 0.03, a statistically significant decrease in mean arterial pressure of 6 millimeters of mercury, p-value 0.009, and there was no change in body weight observed. The limitations of this study are significant, some of which are as followed. There was no control group in this study. The study size was extremely small, with the trial beginning with 14 participants, 3 of which were dropped during the study for various reasons. The home practice requirement of at least 20 to 30 minutes of directed meditation 6 times per week leaves room for noncompliance. However, compliance with the home practice was reported to be excellent, with subjects reporting a mean of 6.5 sessions per week, averaging 24 minutes per session. Still, this data was collected on a self-reporting basis. A wide range of mindfulness techniques were also taught to participants, so it cannot be determined which technique is responsible for the observed results. There were also several strengths of the study, including that the study used quantitative means to collect data on both physiological and psychological phenomena, which forms a tight relationship in our group of studies. The inclusion and exclusion criteria were highly specific and likely resulted in the exclusion of information that would skew collected data, and data of compliance with the home portion of the study were collected on a weekly basis. Furthermore, the MBSR program curriculum followed that developed by the University of Massachusetts Stress Reduction Program, and this research was fully supported by the Diabetes Action Research and Education Foundation in Washington, D.C. The implications of this study was that although the study has significant limitations, it sheds light on tactics to manage one of the most prevalent preventable diseases in the world. As well, its applications may not be limited to type 2 diabetes. These results could be applied to several widespread pathologies that have significant psychological and psychosocial implications, such as cancers, coronary artery diseases, COPD, and more.
Sustained effects of a mindfulness-based stress reduction intervention in type 2 diabetic patients. The objective of the study was to examine the effects of mindfulness-based stress reduction on patients with type 2 diabetes. Mindfulness-based stress reduction is an 8-week program that combines meditation, yoga, and intense focusing on various parts of the body. Patients will lie flat on the ground and focus on parts of their body, starting from their toes and working their way up to the head. Over time, this method is supposed to greatly reduce emotional distress and create more effective health behaviors. It was adapted in this study to include thoughts and practices pertaining to diabetes. 110 people were randomized into 2 groups, one group receiving the mindfulness-based stress reduction intervention and the other group only receiving the usual treatment for diabetes. The study was meant to explore long-term outcomes, but the study only shows data for the first year of follow-ups. They wanted to measure albumin levels in the urine and emotional status of the patients. In the first year follow-up, patients in the MSBR group showed lower levels of depression and improved health status compared to the control group. No significant differences in albuminuria were found. Per protocol analysis showed higher stress reduction in the intervention group as well. These values were measured using a urine analysis for the albuminuria, a questionnaire for the levels of depression and stress, as well as a health survey for a more general sense of physical and mental health. Based on these findings, the intervention achieved a prolonged reduction in psychosocial distress, but the effects on albuminuria didn't need to be followed up further. Some of the things the study didn't do quite well as it could have was that the patients had a very low baseline of depression to begin with, so the stress relieving techniques didn't do as much as they originally thought they would. And some of the strengths of the study were the study adds to the sparse literature on stress and late diabetes complications and emphasizes the potential of psychosocial interventions. Some of the implications include that this is the first study to examine a relationship between mindfulness-based stress reduction in relation to type 2 diabetes, and it looks promising that it could really help a patient's emotional distress.
So our 4 articles examined whether or not stress-relieving techniques improve stress levels and general health of diabetes patients.
Learning to control blood glucose, blood lipids, and blood pressure is extremely important because it can decrease the occurrence of serious complications of diabetes, such as cardiovascular disease, kidney damage, blindness, and lower limb amputations. In our conclusion, we found that stress-relieving techniques do improve the stress levels and general health of the diabetes patients. However, there is no significant specific technique that proved to work best.